Thank you very much, Ruta, for this kind introduction. And I'm very happy to be here and with all of you and to tell you what I think about Alzheimer's disease. The question that I want to raise is whether Alzheimer's disease is really a disease. So this is an intriguing question or proposition, and I hope I will be able to convince you that Alzheimer's disease is not a disease, and to call it a disease misleads us when we try to solve the problem that we have with our with patients who have cognitive decline. So, of course, I have to admit that I have no conflicts of interest. Maybe it's unfortunate, but that's the situation. And I want to ask the question again. What is Alzheimer's disease? I think this is an issue. We spend so much time and so much money in trying to cure Alzheimer's disease, but we should first define what we are talking about. What is Alzheimer's disease? And I maintain that we know how it looks, but we don't know what it really is. What do I mean? I mean, when I see patients and who complain of cognitive decline, and I examine them, and in many cases I say, this fits the definition of Alzheimer's disease. I think this person has Alzheimer's disease. And at autopsy, the pathologist can also say, this is Alzheimer's disease. They see the plaques and they see the tangles, and they say, this confirms to the definition of Alzheimer's disease. But that's not enough. This is the way it looks, and we must not always believe what we see. So the definition of Alzheimer's disease, anybody here who is interested in dementia or not, maybe strokeologist, maybe epileptologist, maybe MS person, if a neurologist is asked to write the definition of Alzheimer's disease, they will come up with something like that. They will say this is a clinical pathological entity of progressive cognitive impairment with these specific neuropathological changes that the pathologist may see, and now we can almost see by neuroimaging the plaques and the tangles. But I want to stress that this is a unique definition. I don't think there is any other disease for which the definition includes both the clinical part and the pathology. No other disease. Of course, we know what the pathology is of multiple sclerosis or of stroke, but this is not part of the definition of the disease, and here it's the definition. So this shows that this is really a complex problem, and it is defined by the way it looks, but not by the way it is. So what is Alzheimer's disease? So the clinician may say, this is Alzheimer's disease. I am an excellent clinician, and when I define somebody or diagnose somebody as having Alzheimer's disease, I'm correct. Not always. Maybe 70, maybe 80% of the time. And 20% of the time, these pathologists will say, you are wrong, my dear. So these are the data that come from the best cognitive clinics in the United States, and the pathologists say, sorry, you are not as good as you seem to think that you are. And on the other hand, we may say, also the pathologist may not be correct, because when they see the brains of dead people who come to autopsy, and they define that a subset of these people have what they call Alzheimer's disease, with the pathological criteria that they have defined. Many of them have lived without cognitive impairment. So these are false positive pathological diagnoses, just as we as clinicians have false positive clinical diagnoses. That's why the definition that I showed before demands both the clinical and the pathological part of it. So what is Alzheimer's disease? What is a disease? A disease is not how it looks, it's what it really is. And for now 100 years, we're trying to find out what goes on in the brain of these patients who develop these pathological changes and clinical manifestations that we call Alzheimer's disease. And we came up with a long list of this part. So people thought that maybe it's oxidative stress. And of course, a lot of investigations about amyloid being the important part in the process that leads to Alzheimer's disease. To no avail almost, you know. Now they try to say, okay, it doesn't work in all in more progressed stages of the disease, but maybe initially it would have worked. Tau hyperphosphorylation that we hear so much about. We don't know what causes the hyperphosphorylation. Why is it? TDP-43, mitochondrial disease, blood-brain barrier dysfunction, inflammation, DNA and RNA changes, all these are part of the definition of the processes that people believe are causing the dementing or the neurodegenerative process. And all of them may be right. But the fact that there are so many processes involved means that we don't know what is the process which leads to all of them. And maybe mitochondrial disease is important, but what causes this? And how is this related to amyloid deposition or to tau hyperphosphorylation and so on? This is what the disease is, the processes that go through this. So look at what we know in multiple sclerosis or in stroke about the processes that lead to brain damage so much. And here we don't know, and not for the lack of trying. So I would go further and ask, what is Alzheimer's disease? And I would ask, is it really a disease? What do I mean by this? So of course, diseases do not exist. There are no such things as diseases except in our brains. So this is, of course, disease is an abstract concept. And it encompasses in a central part the pathogenesis of the disorder. And to give you an example or to show you how I look at it, I will give you an example that everybody here in the room is aware of. So if we talk about pneumonia or about hepatic cirrhosis, is hepatic cirrhosis a disease? If I would ask you to raise your hand, those who think that it is, and then those who do not believe that it is, let's see if we can do it. How many people in the room think that hepatic cirrhosis is a disease? Okay. How many think that it's not a disease? Okay, about 50-50. So what is the issue here? The majority, I think, voted that it is a disease, because there are many types of hepatic cirrhosis. Okay, and I put a short list here, but it can be much longer than that. So hepatic cirrhosis is in many forms, and each of them is different in its pathogenesis, in its cause. And of course, if you want to prevent hepatic cirrhosis, it's not enough to immunize against hepatitis, because this will not protect you from overindulging in alcohol and vice versa. So, and the point is that all these different forms are called by the same name of hepatic cirrhosis is because they share the clinical manifestations and they share the biomarkers, they all have high bilirubin or transaminase, they share the pathology. The pathology is the same, regardless of the cause. So having the same clinical manifestations and the same pathology and the same biomarkers do not define this as a disease. Okay, and this is very important. And you can do the same thing about pneumonia. So we say the patient comes into the emergency room with a pneumonia. But then the important thing is, so we make the diagnosis of pneumonia because of the clinical manifestations, because of the biomarkers like PO2, and because of the X-ray thing. But actually, we have to define what causes this. And if we give it antibiotics, it may work, not if the cause is viral. So of course, we have to define what is the cause. So that's why I think that it's important to realize that actually we have what we call phenotypic convergence. Many different causes, many different processes can lead to the same thing. What can the liver do if it's injured by whatever reason? It leads to fibrosis, which we call hepatic cirrhosis. It's the same, of course, with stroke. It's not enough to say that the patient comes into the emergency room and had a stroke. We have to define what is the cause of this stroke in this individual. And this is something that we can do or should be able to do very well in stroke, of course in cirrhosis, but not in Alzheimer's disease, which is a different category. So in Alzheimer's disease, we should differentiate between early onset Alzheimer's disease. So Augusta D., the patient of Alois Alzheimer 120 years ago, we now know had the genetic disorder. She had a mutation in presenilin 1. Now we know this for certainty. Of course, Alzheimer was not aware of the genetic cause of it, but it did not report any family history either. But now we know that this is a genetic disorder. So personal dementia, which is described by Alzheimer, is actually a rare orphan disease. It is not an early onset of senile dementia. So in patients who have APP mutation, for example, personal dementia, for them, it is a disease because we know what is the cause, we know what is the process, and we understand the clinical phenotype. And these genetic disorders, the monogenic disorders causing early onset Alzheimer's disease can now be cured, So if a person has presenilin mutation, then of course they can be cured. We can just eliminate this abnormal gene. They have another presenilin gene in the other chromosome which is uninjured, and if we just silence one of the abnormal gene, the person will be okay. So if we have an infant born to a parent who had this and presenilin mutation, we can eliminate the disease. We don't do it yet, but in humans with Alzheimer's disease, but we shall be able to do it tomorrow or next year. It is now with the modern genetic manipulation techniques, this is done. So this is for the early onset disease. But what about the late onset Alzheimer's disease, the senile dementia that we call Alzheimer's disease now, which is a different story because it does not have any single cause of it. So we don't know, for late onset Alzheimer's disease, we don't know the cause, and most importantly, we don't understand the underlying process. And again, I mentioned several possibilities that are being investigated. None of them is sufficient. All of them may be correct, but for different patients. So, but clinically, the sporadic Alzheimer's disease is a multifactorial disorder. So unlike the other disorders that are being spoken about here, in this meeting, Alzheimer's disease in particular is a multifactorial disorder, and any one of you can say what are the risk factors for dementia, age, of course, gender, women are more predisposed to this, poor education. We are lucky. We who have been to schooling, high school, university, are protected quite significantly just by having an education from developing dementia. Not completely immune from this, but quite so. Head trauma, and of course some genetic factors. But more important than this are what I call the hyper risk factor. Hypertension, hyperlipidemia, hyperglycemia, that's diabetes, hypernicotinemia, that's smoking, hyperhomocystinemia, hyper-risk, and all these risk factors, hyper-risk factors, can be manipulated, of course. And then there are also very important lifestyle factors in dementia: loneliness, alcoholism, overweight, poor sleep, poor physical fitness. All these are important. And the message is that there are many contributing factors to late onset Alzheimer's disease. And not two persons in the world with Alzheimer's disease have the same risk factor in the same combination. Each one is unique. And it is unlikely that all these different causes have the same pathogenic mechanism. Each one has its own mechanism. We don't know how loneliness or how hypertension causes the biological changes that occur in the brain. So we have no clue to this question. How do these risk factors affect the biological changes? So we clinicians are looking at the clinical risk factors, and the biologists look at what happens in the brain. And these are two parallel routes, and they don't meet. We don't understand what the risk factors are causing. So I think because of that, we cannot call Alzheimer's disease a disease in the sense that I defined before. Actually, Alzheimer's disease is a syndrome. The clinical manifestations are caused by a different set of factors in different individuals. And remember phenotypic convergence, like hepatic cirrhosis, same in the brain. So many different processes can lead to the same neurodegenerative end result, which was defined by pathologists as Alzheimer's disease. And the similarity of the clinical and pathological picture of young onset, early onset Alzheimer's disease and late onset Alzheimer's disease is due to phenotypic convergence. And to use these animal models, transgenic mice, who have these mutations that cause early onset Alzheimer's disease, and try to get from them a measure of how to deal with late onset Alzheimer's disease is basically incorrect. These are different disorders. So to illuminate this, Down syndrome is of course a disease, because in Down syndrome we know what is the cause, that it's trisomy 21, 3 times 3 copies of the APP gene, and this is what causes the disease. So it's a disease, it's not a syndrome. But late onset Alzheimer's disease is not a disease, it's a syndrome. So Down syndrome is a disease, and Alzheimer's disease is actually a syndrome. But it's a unique type of syndrome, because unlike hepatic cirrhosis, in which each person has a single cause, either alcoholism or hepatitis or whatever, here we talk about multifactorial disorder. There are many, many different causes or factors that cause it. And therefore, because of this, I'm afraid that late onset Alzheimer's disease is incurable. We should not expect to find a cure for Alzheimer's disease. But we should not be pessimistic. We can delay the onset of cognitive deterioration, and we can do it, and we should be able to do it, and we should address the risk factors early. So vascular risk factors or smoking. It's not enough to say that to take this person who's now 70 years old and say, let's treat your hypertension. It's just like a person who has lung cancer and you tell him stop smoking. That's too late. You should have done it in their 40s, in their 30s. We here in this room should look at ourselves and to look at our children and to look at our grandchildren and make sure that they know what are the risk factors, how we can delay the onset or maybe even prevent the occurrence of dementia. So these are very important points that I hope I convinced you that Alzheimer's disease is not a disease, that the cognitive deterioration in old age is preventable, or at least we can delay it substantially. And this is what we should do. This is our task as physicians to try and do. And with this, I will end my presentation, but not before telling you that we'll hear more about this and other things in London exactly 1 year from now. Please make sure that it's on your diary and that you'll be with us there as well. Thank you very much.